When you hear the term C-section, you probably picture this one single decisive moment in an operating room, right? But the reality is so much more than that. Today, we're going to pull back the curtain and look at why a cesarean section isn't just an operation, but a whole journey of care. A clinical continuum that actually begins long before the day of birth. Okay, so at its heart, a C-section can go one of two ways. On one hand, you have the planned elective procedure, which is often based on someone's medical history. And then on the other, it can be an unplanned, emergency surgery because of complications that pop up during labor. The entire goal of modern prenatal care is to manage this journey, to support a normal pregnancy while also acting as this super vigilant early warning system for when the plan might need to change. Now, here's something that might surprise you. The very first step toward a safe planned delivery has absolutely nothing to do with the surgery itself. It's all about getting the timing exactly right. And that brings up a really crucial question for both doctors and for parents-to-be. If you're planning a birth, how can you be 100% certain you aren't scheduling it too early? How do you know? Well, the answer is in something called the definitive window. Clinical guidelines are incredibly specific about this. To nail down the most accurate due date, an ultrasound has to be done between 11 and 14 weeks. They take this key measurement, the crown rump length, or CRL, and this has become the absolute gold standard. It's way more reliable than just dating from the last menstrual period. And that is exactly why this precision is so vital. Getting the date wrong isn't just a minor mistake, it can lead to what's known as inadvertent iatrogenic prematurity. I know, it's a mouthful, but it basically means harm caused by a planned delivery that unintentionally happens too early, creating really serious and frankly, completely preventable risks for the newborn. All right, so once that timing is locked in, the journey of care moves to the next phase, a holistic risk assessment. And this means looking at the whole person, not just the clinical facts of the pregnancy itself. Of course, clinicians start with the patient's history, a previous C-section, any history of physical trauma, or medical conditions like heart disease or diabetes. These are all key indicators that help build the initial blueprint for a safe delivery. But the assessment goes way deeper than that. Other factors can seriously ramp up the complexity of the surgery. A body mass index over 30, for example, creates unique challenges for both anesthesia and the operation. And a history of endometriosis is a huge red flag because it can cause dense internal scarring that absolutely requires the skill of a very senior surgeon in the room. And this is the crucial point. A truly comprehensive safety plan has to look beyond the purely clinical stuff. It has to address the powerful social factors that have a direct impact on a patient's health and safety. I want you to just think about this number for a second. 1 in 7. That's how many maternal deaths happen in patients who have disclosed domestic abuse to a healthcare professional. It's just a staggering and sobering statistic. And this is part of a much larger systemic problem. Confidential audits in the UK have confirmed that social and ethnic inequalities are the main drivers behind the recent rise in maternal mortality. The data shows that women from minority ethnic backgrounds face significantly higher risks, often because their concerns are dismissed due to systemic bias, and mortality rates are consistently highest in the most economically deprived areas. To even begin to address this, a mandatory professional standard has been put in place. Every single pregnant patient must be seen alone by a healthcare professional at least once during their care. This creates a safe, private, and absolutely essential opportunity to disclose sensitive information without fear. So this really complex web of factors leads us to one of the most nuanced decisions in all of obstetrics, the choice between a repeat caesarean section and what's called a VBAC, or a vaginal birth after caesarean. The conversation around this is a delicate balancing act. It has to weigh the patient's desire for a vaginal birth against the very real risks that come with labor when there's a scar on the uterus from a previous C-section. It's a really personal decision. A landmark investigation, the Ockenden Review, put a sharp focus on this. It found that, in the past, safety was sometimes overlooked in the pursuit of vaginal birth, and the report's main recommendation was an unequivocal shift. The decision-making process must always prioritize safety above all else. This brings us to a really crucial long-term perspective. See, the decisions made during one pregnancy don't just affect that single birth. They create a legacy that impacts a person's entire reproductive future. Think about it. A scar on the uterus from a C-section becomes a permanent part of the patient's medical story. It can increase the risk for certain complications in future pregnancies, like the placenta implanting over the scar, and it fundamentally changes the safety protocols for any subsequent births. So, after navigating all these different factors, from the precise timing and clinical risk to personal choice and future health, what is the ultimate goal of all this work? What are we trying to achieve? Well, the goal isn't just about achieving a certain type of delivery. It's about bringing together three core pillars: holistic management that sees the whole person, truly informed decision-making based on clear and culturally appropriate communication, and an unwavering focus on patient safety.
At the end of the day, success in modern obstetrics isn't measured by whether a birth is vaginal or cesarean. Success is measured by the health, safety, and well-being of both the parent and their child. That's the only outcome that matters.
Which leaves us with one final important thought to consider. As our medical technology gets more and more advanced, how do we make absolutely sure that the human side of care, that compassion, empathy, and professionalism, doesn't just keep up, but actually continues to lead the way in ensuring every single patient is safe?